Hey, it's Dr. Centeno, and let me make sure. Hi, it's Dr. Centeno, and don't really have a topic today, so I'm just going to do an Ask Me Anything session. The reason for this kind of off-the-cuff session is my mother passed away this week, and she had been ill, so it was actually a blessing. But obviously a lot going on, and that means I won't be able to do this on Monday. So I wanted to get on here for just a half hour today and see if anyone had any questions. We didn't really advertise this because I didn't know what I was going to be able to do because I had another meeting this morning. I've got a meeting at 1:30 my time. So I wanted to get on here and see if anyone had any questions. I wanted to at least spend a half hour answering questions since I won't be able to do a presentation today on a specific topic. And next week, on Monday, I won't be able to do this because that's when her memorial service will be. So any questions that anyone has out there about interventional orthobiologics, craniocervical instability, anything like that, this would be a good time to jump in there, and happy to answer any questions you have. Just to update, today we'll just be doing an Ask Me Anything session, so there won't be a presentation. Yeah, if you've got questions, I'm here to answer those questions. Lucy, jaw bones losing teeth. Not quite sure what the question there is, Lucy. So let me know a little more specifics on that one. Jeremy, have you treated many patients with cervical instability from fluoroquinolones? Jeremy, we've certainly treated a lot of fluoroquinolone tendinopathy patients. I don't know that we know that fluoroquinolones at this point cause cervical or craniocervical instability, meaning I don't think there's any published data on that, but we've certainly treated a lot of patients with tendinopathy from fluoroquinolones. For people who don't know, fluoroquinolones are an antibiotic class that have been shown to interfere with tendon cell metabolism. So you can get a tendinopathy problem. And in my experience, it's been fairly easy to fix with just PRP injections into the tendons. It's kind of interesting because I know there's lots of people suffering from fluoroquinolone problems out there and on the tendon side. And it's interesting to me how well it responds to interventional orthobiologics. John, can you drink coffee, caffeine after PRP? Yes, I don't see any reason why you shouldn't be able to drink coffee or caffeine after PRP. Just realize that you want to, as best you can, clean up any metabolic syndrome issues that you have, because that's going to make all of your tissues better. It's going to reduce systemic inflammation. And the only reason I bring that one up is that we see scenarios and situations where for about half the population, coffee doesn't really, and caffeine in general doesn't really impact them at all from a metabolic standpoint. But for the other half of the population, it has a very strong effect on, a negative effect on blood sugar. And blood sugar control is one of those things that stokes inflammation or blood sugar out of control. So in the bigger picture, it may or may not be part of something you have to do to clean up a metabolic syndrome, but there shouldn't be any direct contraindication to coffee and caffeine after PRP. Levon, hi, Dr. C. I had a PICL on August 30th. Feels great while running. High impact exercises should be avoided. Is allowed to use sauna 80 to 100 C or light weights. Yeah, so sauna is not a problem. Just realize that we've seen in some patients that infrared or red light therapy, and there's a lot of infrared saunas out there these days, can sometimes stoke a little bit too much inflammation in certain patients. So just be careful about that, but there's no direct contraindication to using a sauna. As far as lifting light weights, if you were doing it before and it wasn't aggravating you, then you can return to that. But if before the PICL, lifting light weights would always cause problems, then I'd stay away from that. John, if there's a tear in the nuchal ligament, would you lean towards performing one BMC procedure versus 2 to 3 PRP treatments? Well, John, I don't know how you would identify a tear in the nuchal ligament. None of the MRI technologies we have at this point are really good enough to do that unless you go down to something like 1 millimeter slices, sagittal, which are pretty hard to find. With something like a 3 Tesla magnet with a head coil. It's not something you're going to generally see really well on an ultrasound. So I'm not quite sure how you would diagnose that. So I need to know a little bit more. John, do you think the difference between using 10x PRP versus 15x make a big difference when treating instability in a younger individual? No, not in a younger individual. It would take someone middle-aged or older for that to start to make a big difference. So realize that the effects of PRP are age dependent. So when you are treating someone who is young, let's say in their 20s, high concentrations really don't matter. You're going to get the same result from a high concentration as you would from a low concentration. And then we get into that age 35 or older, what I call the NFL retirement age, right? There's a reason why NFL players tend to retire at around 35 years of age. That's when we start to have less native repair capabilities as we start into middle age. And those guys can no longer, wake up the next morning or spend 2 or 3 days sore and feel great again. They start getting cumulative wear and tear because of decreased repair. So once we get into that 35-year, let's say 35 to 45-year range, then you're going to want that higher concentration. You don't need crazy high concentrations. So now we're into sort of, depending on what we're treating, the 5x to 10x range. And then once you get past 45 or 50 or so, now we're in a situation where 15x works better than 10x. Jeremy, why don't you use adipose tissue stem cells for cervical injections? Simply because, Jeremy, they're higher risk, meaning that a liposuction has about 100 times the medical risk of a bone marrow aspiration. And think of it this way. I've done adipose tissue stem cell injections. And the biggest problem is it's my job as the doctor to liquefy structural tissue to get it to come out. So if you're doing a liposuction to pull out adipose tissue, elbow grease matters. And that sounds a little gross, but it's accurate, meaning that the more elbow grease or force I put into that type of harvest, and the more tissue I disrupt, the better result I get with getting those cells out of there. Now compare that to a bone marrow aspiration, where just like taking blood, you put a catheter inside a vein, or in a bone marrow aspiration, you work a trocar through the plasticky like bone, and then you pull from that bone. So that's the reason why we've never drifted that way. There's also not a lot of data that shows that it's any better than doing bone marrow. So if I've got a less invasive draw procedure versus a more invasive one, and there is no advantage of one over the other, then I'll take the less invasive draw all day long. Rishi, is it better to go above and below the atlas in the first PICL? I spoke to patients who did the PICL that they advised. They're often asked which they prefer. I understand this is based on the person individual case. Yeah, so the bottom line is it really depends on the patient. If the patient is in that fragile category or centrally sensitized, then less is more. So we will stay below. Or if we don't really know how the person's going to respond because they haven't done much prior interventional care. Now, if we have the opposite, right? This week I had two guys from the UK, and they were both rugby players. I could just tell based on physical exam and history, they were about as hardy as you could get. So I didn't hesitate to go above and below on both of those. One of those was the second procedure. But one of them was a first procedure, traveling from the UK, extremely hardy individual, no physical exam or history of central sensitization. So I didn't hesitate to do that. So it has to be individualized to the patient. Regenetics been advanced by Harry Winston. I read your blog on exosomes. Is it dangerous to get these treatments given the fact the FDA has given them a no? Yeah, Harry, I would just say that we know almost next to nothing about the safety profile, the published safety profile of exosome treatments as they're on the market today. So because of that, we don't use them at all. We also have no clinical data showing that they're effective for any type of musculoskeletal condition. So just doesn't make any sense, right? It's about as good or about as powerful as a PRP injection. I can dose a PRP injection. There's 100 randomized controlled trials published for PRP versus 0 goose egg for exosomes. So it's an easy choice for me as a clinician, but as from the patient standpoint, yeah, we don't have any safety data. So I have not a clue whether or not exosomes are safe, and nor does anyone else. Rishi, is facial pain, trigeminal neuralgia, a hard one to treat? You have many successful stories treating this. Heard you say in previous video that facial pain was a tricky one. Not necessarily a tricky one. We have patients with facial pain. Now, I've seen a lot of misdiagnosis of trigeminal neuralgia out there, meaning the most common misdiagnosis would be someone with a V2 pattern who actually just has a TMJ problem, but saw a neurologist who didn't really understand how to diagnose TMJ, and they got put into the trigeminal neuralgia category. But as far as the patients who have legit trigeminal neuralgia and CCI who we see, most of the time that goes away when we treat the CCI. If it doesn't, we can directly treat the trigeminal neuralgia. Again, like everything I discuss here on this show, it's always a risk-benefit equation, right? We want to make sure that we're not exposing the patient to more risks than they need to be exposed to. Rishi, would seeing Dr. Scott Rosa before seeing you be beneficial in terms of treatment plan? Dr. Rosa is quite expensive, so just wanted to know how much this analysis reporting imagery would help in treatment with you. Any chances would change treatment plans significantly and give you more precision? Yeah, as I always tell patients, I will always take more information rather than less. In addition, Scott Rosa is pretty brilliant in this area. Now, if you're in a situation where we've already diagnosed CCI and we've got a pretty good handle on what it is you've got, then and you're really struggling to financially to afford all of this stuff, then I would say, yeah, probably may not make sense. Meaning if you're going to have to take from one hand and put it in the other hand, or take from one thing and put it in the other thing, then you may want to not do that. Having said that, if cost isn't the driving factor and you want to have the absolute most amount of information for me to review, then seeing Scott would be great. Amen. Hello, Dr. Centeno, I'm taking SSRI meds and I'm feeling 70% better. Is this a thing with CCI, AAI? Well, we can certainly see depression in all chronic pain patients, whether or not they have CCI, AAI. And that comorbid depression can make things worse subjectively, right? There's a certain amount of pain, and then that pain experience can get amplified by the depression. So that's a good thing. And I would encourage you to continue down that road and see, once you get rid of the depression, what's left. And then if you can live with what's left or not. But depression is really, really common in chronic pain patients. But again, all types of chronic pain patients. There's nothing specific to SSRI meds and AAI. John, if a hypermobile patient has damage to only their posterior ligaments, can it, over the course of a couple of years, lead to alar ligament laxity? It can be prevented by getting treated posteriorly. Not that I have seen, John, as far as one bleeding into the other. Rishi, I'm seeing in early December. However, I've got a new symptom recently, which is trigeminal neuralgia. The symptom is mainly an aching sensation behind the nose area only. I do not have electric shooting pains to the face, as many report trigeminal neuralgia. Is waiting from now to early December too long to get this treated? I'm worried about permanent nerve damage to my face. Pain's about a 4 out of 10 constantly. I don't think I'd be too concerned about getting a permanent issue over that time frame. When I talk about permanent nerve damage, it's not the difference of months. It's usually the difference of years. So the difference of seeing somebody who has 3 to 5 years of ongoing nerve stuff and doesn't ever get that treated versus seeing someone within that first year of having the nerve issue. Era, at what point you're too far gone for stem cells? Is there a point where it becomes dangerous? Since you get worse before you slowly get better, would a set of high cervical PRP followed by PICL be a better strategy since it heals faster? So, Era, I think you're talking about CCI here. And yeah, I would need to look at all your clinical information to see if things were too far gone for a procedure like PICL. But certainly we have patients who would rather do a posterior PRP as sort of a half step, see how they do with that. And then assuming everything goes well there, they would move on to PICL. And if that didn't take away their symptoms. So we have patients like that. We work with patients like that. Obviously, there isn't really a one size fits all answer for everybody. And we want to make sure that we work with people so they're comfortable with what we're doing. So yeah, I would say not a problem to do the PRP or the posterior PRP first. Rishi, do you believe the myelin sheath gets worn away, causing trigeminal neuralgia? In your experience, what likely causes this inflammation? Not so much. I think it's more related to movement of the skull base versus the brain itself. And that can cause some irritation of the fifth cranial nerve as it goes through the skull base, or movement of the skull against the atlas. So that's, I think, what causes this. Caleb, hi doc, thanks for replying to my email regarding the video with TMJ Prolo. Still pretty crazy how it took a single injection of 50% dextrose, but a single PRP procedure produced the same results. Yeah, Caleb, that obviously all depends on the patient. Do we have TMJ patients who get a single PRP treatment and do great? We do, but it's like comparing apples versus oranges versus pears versus pineapples. It's hard to get a sense of who that patient was. Again, as I talked to you, I think in the email, and this is important to bring up. I know I've talked about it before. As we increase the concentration of our prolotherapy solution, we're increasing the potential for neurovascular damage. So bringing it up to 50% just maximizes that neurovascular damage. And in particular, for the TMJ, you've got the temporal artery that supplies blood to this area that runs through there. So if you were inadvertently to inject into that temporal artery, which that dentist could have done because they just did a good old-fashioned 1960s blind injection into the joint, you would likely kill off the temporal artery and lead to a whole other big set of problems. So I don't think it's smart to use 50% Prolo for that reason. Vivan, what do you know about sedation-induced side-lying arterial and venous flow of spine ultrasound? Let's see, not quite sure. Sedation induced, side lying. So I'm assuming it's in a side lying ultrasound with sedation, looking at arterial and venous flow. How do muscles laxity change blood flow? When I sleep, I have much worse pulsation in head, ears. Well, the first thing would be ultrasound is not a great way to look at the arterial venous flow in the area we're talking about, the upper cervical spine, because it's heavily operator dependent. And it's also very movement dependent. So a better way to do that would be using something like a CT venogram. And then as far as putting someone to sleep and having them lie on their side and then doing the ultrasound, I don't know that we have any data on what those numbers should be in that situation. John, are there any supplements you should avoid after PRP? Not so much supplements, but I would certainly avoid nonsteroidal anti-inflammatory drugs for sure. That's a big one that we see. And corticosteroids. So corticosteroids would be things like a steroid inhaler or taking steroid tablets or getting a dexamethasone shot, stuff like that. Regenex's been advanced by DB. Can a vagus nerve problem cause leg pain? And if so, what would be the best treatment? No, very unlikely that a vagus nerve problem would have anything to do with leg pain. Maya, hello. I tried to stretch my neck today and heard a cracking noise on the right side at the base of the skull. Only had a bit of pain, but also pain in the right nostril. Idea what that could be, maybe a nerve. Yeah, Maya, I mean, it's certainly possible that you might have gotten a little bit of irritation of the second branch of the fifth cranial nerve, because that can go into or cause pain inside of the nostril. As far as the rest of it, yeah, I would need to know more. Sarah, hi, Dr. T. Thank you for successful PRP procedure yesterday. When I've been taking Percocet for pain, I get very nauseous, or anything over the counter that I can be taking for nausea while on Percocet. Yeah, so Percocet can cause nausea in some patients. Best thing to do would just be to switch the pain medication from Percocet to just extra strength Tylenol, because usually, if we start giving you medications to treat the nausea caused by one medication, that's not a great thing, or change the pain medication. But the smartest move would just be get rid of the Percocet and switch it out for extra strength Tylenol. Caleb, when you fill the C0, C1 joint and C1, C2 joints with PRP, if I'm correct, you were trying to accomplish these things: reduce inflammation, strengthen cartilage, and surround capsule from the inside. That amongst other things, but yes. James, I live in Connecticut, and there's a Dr. Southern as part of our Jenks network. Can I get any blood or tissue sample needed? Can I get any blood or tissue sample needed for the PICL procedure done here in Connecticut? I'm not quite sure what you mean by get any blood or tissue sample needed. You would need, so again, all upper cervical work occurs in Colorado. None of our Regenexx doctors are certified to do upper cervical. When it comes to a blood or tissue sample, I think what you mean, but maybe you can correct me if I'm wrong, is can you get blood or bone marrow taken out there? The answer is no. You'd have to do it all in Colorado as part of a same-day procedure. Caleb, you mentioned how dextrose works better than PRP in EDS patients. Excuse me. Have you seen EDS patients respond well to plain PRP, not lysate plus dextrose, when treating damaged ligament? So we've used, as you call it, plain PRP, but looks at poor PRP in EDS patients, in my experience, that they don't respond as well. They tend to respond better to a dextrose prolotherapy solution or bone marrow concentrate. But again, lots of different genetic types of EDS out there, or HEDS. Best of RuneScape, PRP or stem cells, regenerative TMJ, which you have seen better outcome for. All depends on severity. So if we're talking about a very severe TMJ, then that's more on the stem cell side. If we're talking about a moderate to mild TMJ, then that's more on the PRP side. Era, if you dislocate or sublux C0, what scan would best show that MRI or CT scan, since it can be made 3D? Is it flexion extension needed? And the same with C1. Well, if we're looking for, I see, 3D, not in CCI types, but three-dimensional. Yeah, so as far as dislocating or subluxing C0, C1, DMX is not as good at looking at that. Usually a flexion extension MRI, upright MRI, is where we see those issues. Sarah Morris Morano, Centeno, I'm 8 weeks out from my first PICL. Things sometimes seem better and sometimes too hard to tell. I'm EDS patients, things are very convoluted. My question surrounds the new symptoms. Feel like something is quickly and sharply slipping off of something in C0, C2 area, followed by rapid tightening of trap muscle. Didn't used to tighten. I overall have fewer symptoms. But what would you generally say about new symptoms post-PICL? Yeah, Sarah, I think what we tend to see is that there's, in most patients, there's the first 2 to 4 weeks where they sort of get that. Things are tighter because things are inflamed. And then as that goes away, things get looser and you're nowhere near far enough out. We don't even look at any type of outcome until the patient gets into the 4-month range, sometimes 3 months, but usually 4 months. So you got about 2 months to go before we even look at all of that. Now, if you have been seeing a NUCA or AO chiropractor, then a NUCA or AO chiropractor would be good to go back to, because there may, sometimes we'll see the vectors change with regard to their adjustment. John, how do you treat IJV compression? Do you inject the IJV area itself? Yeah, John, so important to know, number one, that IJV compression is a normal variant in patients without symptoms. So anywhere from 1 in 3 to 1 in 5 patients are walking around out there with pretty moderate to severe bilateral IJV compression, and they have no symptoms at all. So we're not really treating IJV compression because that's a normal variant found in people without symptoms. Now, what we are usually treating is the instability that leads to intermittent IJV compression, in addition to compressing other things in that area. And that's about treating the cervical instability. So we don't inject the IJV area itself. John, do you know anything about A2M? Do you see any benefit of mixing A2M, PRP, and putting it in a damaged tendon or ligament? No, sometimes BMC and PRP are mixed together. Yeah, John, we've used A2M. It can be mixed with PRP, and it would make the most sense to use something like that in someone with a very pro-inflammatory type of arthritis. Let's say a heavyset person, high triglycerides, poor blood sugar control, mild to moderate high blood pressure. That's the kind of patient where adding a little A2M into PRP can sometimes make a big difference. Also, those patients tend to get big knee effusions, so their knee swells up frequently. So, but as far as putting it into a tendon or a ligament, probably not going to have the same effect as what I just described. John, so true that L ligaments are cord-like and very strong compared to the many ligaments in our body, meaning it's more likely to sprain the posterior ligaments compared to the anterior ligaments. I think we more commonly see for sure translation instability in the neck at C2-3 down to C6-7, and less commonly see injuries to the alar transverse ligament. Having said that, obviously I've got a practice full of injuries to the alar transverse ligament. NARS, upper cervical chiropractors told me in the past, don't get PRP until you're in good alignment. What's your opinion on this, please? Well, what will happen if you get PRP, you're not in good alignment? I've been told I'm holding my adjustment for over a year, but I still don't have any relief. And I'm considering PRP, but upper cervical chiropractors told me to give it more time. And they said, because I'm holding my adjustment, they don't believe I need PRP, but I believe they are incorrect. Yeah, so I think the first question would be, do you have craniocervical instability? That would take movement-based x-rays. That diagnosis can't be done on static adjustment type x-rays or on cone beam CTs, etc. And if you don't, and you're holding for a year, then you may have damage or injury to the upper cervical structures that are causing symptoms, and those might need to be treated. I think the disconnect here is they're talking about, do you have a lot of instability? Because you're holding, it doesn't seem like you have instability. They may not know or understand that your symptoms may be coming from a damaged, let's say, C1-2 joint, and that C1-2 joint itself can also be treated with PRP. So I think there's just some miscommunication going on there. Zach, has your team looked into the ketone body, BHB inhibiting, inflammasome, research just inhibiting, help with IVG? Yeah. I mean, again, I think we're getting into the angle, the dangle, and the squiggle, the wiggle here. That's what my brother used to call it. Meaning that we're looking at complex systems that are chaotic and interact with hundreds of other systems. So while you may get some effect from inhibiting a specific portion of the inflammasome, you may also kill somebody. You may also damage another system. For example, nonsteroidal anti-inflammatory drugs work by inhibiting cyclooxygenase 1 or COX-2. But we know that when we do that, we damage the stomach. So regrettably, probably not going to be that simple. Kenneth, hello, sir, is there a benefit in using low light laser therapy immediately, PRP within 5 days? We don't know if there's a benefit to that, but it probably wouldn't hurt things if you did that. John, wait, so it's unlikely that a hypermobile patient with postural laxity only develop loosening of the alar ligaments years later. Yeah, John, but there's other things that could certainly cause overload of alars, like head forward posture, things like that. Bo, I have my DMX and I'm trying to get my upper right MRI with flexion extension images available for my telemedicine appointment. Should I reschedule my telemedicine appointment if the MRI images are not available by my appointment? So Bo, a lot of that depends on what it is we're trying to get to. So if you have findings of CCI in your DMX, the purpose of a telemed appointment is really to get over the hurdle of your PICL or posterior injection candidate. And then obviously we're not going to refine that treatment plan until we do a physical exam and we see that person for an exam in the clinic. So my sense is, as long as you can get the MRI done before you get into the clinic and there is CCI on the DMX, then keeping the telemedicine appointment really won't change much versus delaying it. Kenneth, hello, sir. Is there any benefit in using low? I think I got all of that. Need to advise people here to avoid 1-2 capsule injections, treat overhang. There was a woman who got over tightening of that capsule. Her symptoms completely resolved, but she has no mobility now. Yeah, Caleb, probably not possible to make no head mobility. Probably what could have happened there is that the doctors who thought they were doing a C1, C2 capsule injection were just blindly sticking the needle in there And they may have damaged the C1, C2 joint because the C1, C2 joint is responsible for 50% of head rotation. And let's see here. I'm going to have to start shutting this down because I do have a 1:30 meeting. So I'm just going to take a few more and then close this out for today. Jennifer, I posted her injections 5 weeks ago. My doctor here stopped my muscle relaxer. A few days later, I'm back on it now, but I'm very flared up. I think PT would help because it did last time it happened. When can I start PT again? So I'm not quite sure what the question is. It sounds like the muscle relaxer got stopped. That caused you to flare up. And so PT helped the last time that happened. I would definitely go do that. So that shouldn't be a problem. What vertebra affects fifth cranial nerve? Usually not a vertebra. It would be the skull on the atlas. So C0, C1. Fatchen is amount of crepitus around atlas, indication of instability severity. The more laxity, the more noisy it gets with certain neck movements, or it means some calcification of ligaments might be ongoing. Usually not an indication of severity. James, necessary to have another person with you and come to Colorado for a PICL procedure? Are there any alternative options? Someone who does not have someone to come with them. Yeah, James, we do have a nursing service that goes to and stays with the person that first night, because that's really what we try to do, is to make sure that for the first night, that person has an advocate who can assist them or help them if there's any issues they're having. You know, for example, we've seen people get up and go to the bathroom in the middle of the night. They're in a strange room. You know, they're in a lot of pain, maybe from the procedure, or they're taking some meds from the procedure, and there's not light, and they trip in the bathroom. Well, obviously, if something like that were to happen, you'd want someone there who could assist you. So yes, we have that service. Sarah, I'm correct that you would not recommend starting a new therapy post-PICL to look at new symptoms if the patient was not doing that therapy prior to PICL. In general, yes. Would you recommend human growth hormone to help with healing? John, I don't think it'll help with healing a lot from a bone marrow construct procedure, because we did that research many years ago. Having said that, if you wanted to be on human growth hormone for overall health, that would be fine. Caleb, any contradiction taking salt tablets prior to PRP? There's not. Ciaran, what are your thoughts on palatal expansion after a PICL procedure? You could get that done. I don't know what the reason for it would be, so I'd need to know a little bit more. If one dislocates C0 through C1, it would still be attached ligaments, wouldn't it? I think it may have dislocated and suddenly developed pretty bad dystonia. It kept pulling and twisting. Fear I can't get undone anymore. Is there any cases of being operated if no choice left? Yeah, to answer that question, Era, I would need a lot more information about what was going on specifically with 01 and whether it was still dislocated, that kind of stuff. Kathy, Hedrick Centeno, I asked you previously on live that my 19-year-old son is UCL laxity without tearing. He's hypermobile. You mentioned dextrose better than PRP. Should we skip to BMC? Yeah, a lot of that, Kathy, depends on the amount of injury and damage. AT, difference in prognosis, pain versus relief upon palpation of suboccipital muscles, different reasoning behind both. Different prognosis, pain versus relief. Not quite sure what you're referring to there, AT. 2 weeks post-PICL when raising shoulders, clicking in upper neck feels like back super tight, pulling on shoulders, pulling on neck. Scared to add modality to make things loose. Sounds like there's still some flare-up, so I think I would just continue to to heal up, and but still flare up from the procedure is what it sounds like. Tanya, hydroxyntino, could curve correction be done before or right after my first PRP procedure with you on December 6th? Should I wait until I have my DMX and you're able to take a look at it? I would wait until I look at the DMX. AT, biggest marrow ring you've seen in first PSCL was the fastest you've seen a patient improve. Well, the fastest would be within that first 3 to 4 months. Those would be the one and done patients, which is about 1 in 5 of the PSCLs we do. As far as biggest amounts of overhang, we've seen 7, 8 millimeters. They don't get too much bigger than that. Okay, guys, well, I'm going to start winding this down. I think I've gone through all the questions. I want to thank you for being here today. In addition to that, just to let you know, because of my mom's memorial, I won't be here this coming Monday like I thought I would be. So I will probably try to get one more of these out on this coming Friday before I take off. And then while I'm gone, I'll be releasing one video a week on the CCI symptom series. So that's where we're going to take a specific symptom like headaches or dizziness and track it all the way back to what causes that in CCI patients. So you all have a great weekend, and I will see you a week from today. Thank you.